We'll be breaking down all major concepts covered on the exam. I'm Harvey.
And I'm Donna. We're MCCQE reviewers, and we want to help you, Canadian medical students, master this exam material and really feel comfortable with the review process.
Yeah, before we jump into our housekeeping stuff, just consider this clinical scenario. What if a patient walks into the emergency department and they present exactly like they're having a massive heart attack?
Like crushing chest pain, severe distress, all that.
Exactly. Maybe even some ECG changes. But giving them standard heart attack medications will actually kill them within minutes.
Wow. Yeah, today we are tracing the vascular tree to find out exactly why that happens.
It's a huge exam trap, right?
Oh, absolutely. And we will break down the exact pathophysiology behind it. But first, for today's deep dive, we are teaching directly from reliable StatPearls articles.
Right. And please keep in mind that this audio is for medical education only. It's not medical advice. Any clinical decision should always involve a qualified healthcare provider.
Definitely. So our mission today is to follow the anatomical plumbing, basically.
Starting high up at the high-pressure central aorta and then working our way all the way down to the peripheral vessels.
Yeah, we're looking at what happens when these vital pipes structurally balloon out or when they suddenly tear internally or when they gradually clog up over decades.
We are focusing heavily on the exam-relevant definitions, the classic presentations, diagnostic thresholds, and of course those really common MCCQE pitfalls.
Right, so we should probably start by looking at the structural integrity of the vessels, before we explore how they actually break. Let's look at aneurysms, specifically the abdominal and thoracic aortic aneurysms.
Okay, yeah, let's get the foundational definition straight for the exam. An arterial aneurysm is a permanent, localized dilation of a vessel.
And the threshold you absolutely need to memorize is that it must enlarge by at least 150% compared to the normal diameter of the adjacent healthy artery.
Right, so we aren't just talking about a slight bulge here.
No, not at all.
We are talking about a massive structural deformation.
Yeah.
And the infrarenal aorta always seems to be the prime suspect on test day.
It really is. And the question is why that specific location is so vulnerable to this kind of massive deformation.
Right. Why there?
Well, it comes down to microscopic architecture. The aortic wall is made of collagen lamellar units, and those provide the structural integrity. But the number of these lamellar units is significantly lower in the infrarenal aorta compared to the thoracic aorta up above.
Oh, interesting. So it's physically weaker right off the bat.
Exactly. And on top of that, the infrarenal aorta lacks a robust vasa vasorum.
Which are those tiny blood vessels that feed the wall of the aorta itself, right?
Right. So meaning the inner layers of the abdominal aorta are relatively hypoxic to begin with.
So it's structurally and metabolically vulnerable right out of the gate.
Mm-hmm.
You add in chronic inflammation, maybe a gradual loss of elastin, and general enzymatic degradation of that connective tissue over decades.
And the wall just inherently weakens.
It actually reminds me of the law of Laplace from physics.
Oh, yeah. That's a great way to think about it.
Right. It's essentially like blowing up a rubber balloon. When you first start blowing air into a balloon, it requires a lot of force. The rubber is really tight.
Yeah, it's super hard at first.
But as the radius of the balloon increases, the wall tension exponentially increases. It gets easier and easier to blow up until it just pops.
It becomes a vicious cycle of dilation and risk. I mean, the bigger the aorta gets, the faster it wants to keep getting bigger.
And that physics principle dictates why surveillance and screening are so highly tested on the MCCQE.
Yeah, the ACCAHA screening guidelines are very specific here. You need to know that a one-time abdominal ultrasound is recommended for all men and women age 65 or older who have ever smoked, or who have a first-degree relative diagnosed with an abdominal aortic aneurysm.
Wait, the phrase ever smoked is critical there, isn't it?
Absolutely critical. The exam might present, say, a 66-year-old patient who quit smoking 40 years ago and thinks they're totally in the clear.
But they still meet the criteria for that ultrasound.
Yes, they do. And it's non-invasive, it involves no radiation, and it's highly sensitive for assessing the abdominal aorta.
But, okay, if we do find an aneurysm, the next major hurdle for the exam is knowing the surgical thresholds, because we obviously don't rush them to the operating room for a minor dilation.
Right. No. The guidelines dictate we consider elective surgical repair when the diameter reaches greater than 5.5 centimeters in men and greater than 5.0 centimeters in women.
Or if we see rapid growth.
Right, exactly. The threshold for rapid growth is an expansion of greater than 0.5 centimeters over a 6-month period.
And naturally, any symptomatic presentation means it's time for intervention.
Yeah, like if a patient is complaining of a new, dull, pulsating pain in their abdomen, you don't wait for the exact millimeter measurement at that point.
Makes sense. But there is a significant exam trap regarding the medical management of these aneurysms while we're, just watching them.
Oh, yes. I was actually just reviewing the StatPearls data on pharmacotherapy for this. For thoracic aortic aneurysms, or TAAs, the standard of care includes using beta blockers or angiotensin receptor blockers.
To control hypertension and reduce the mechanical stress on the thoracic wall.
Right. But for AAAs, abdominal aortic aneurysms, the data shows beta blockers have been proven completely ineffective at reducing expansion or rupture risk.
Wow, okay. You cannot let the exam trick you on this.
No, you really can't. If the clinical vignette asks for the best medical therapy to slow the growth of an unruptured AAA, beta blockers are the wrong answer.
Because the pathophysiology of a AAA is driven heavily by enzymatic degradation, right? Like macrophages releasing matrix metalloproteinase that chew up the wall.
Exactly. Lowering the heart rate doesn't stop those enzymes.
So what do you want to do instead?
You want smoking cessation. That is the absolute paramount intervention, along with statins and general blood pressure control. Prescribing beta blockers specifically to stop AAA growth is basically a proven medical myth.
Which logically leads us to the nightmare scenario. We move from a stable, slowly dilating vessel to the acute, catastrophic failure of that weakened vessel wall, the ruptured AAA.
Yeah, this is terrifying. The untreated mortality rate here approaches 100%.
Because the mechanical stress we talked about with the law of Laplace finally just exceeds the tensile strength of the collagen.
Exactly, just bursts.
And every textbook and prep resource drills in this classic triad of a ruptured AAA. It's hypotension, severe flank or back pain, and a pulsatile abdominal mass on palpation.
Right, the classic triad.
But here's the thing. If this triad is so definitive, why do the StatPearls articles explicitly state that up to 30% of ruptured AAAs are initially misdiagnosed in the emergency department? I mean, that seems like a massive clinical contradiction.
It really highlights the difference between textbook medicine and clinical reality. The word classic in medicine often just means memorable rather than frequent.
Ah, that's a great way to put it.
Yeah, the reality is that this classic triad is actually only present in 25% to 50% of cases.
Really? That low?
Yep. The patient might be obese, making a pulsatile mass impossible to feel. Or, their blood pressure might be temporarily normal because their sympathetic nervous system is in overdrive, compensating for the internal bleeding.
So more than half the time, the clinician is looking at an incomplete puzzle.
Exactly. And this is exactly how the MCCQE will test the concept.
Right. The vignette will describe an elderly male patient with severe, sudden onset flank pain radiating to the groin and maybe some microscopic hematuria. The instinct is to diagnose renal colic, like a kidney stone.
Oh, yeah, that's a huge trap. Another common misdiagnosis is diverticulitis, especially if the patient presents with diffuse lower abdominal pain and nausea.
Or they might present with vague chest and epigastric pain, and an ECG shows some non-specific ST changes.
Right, just due to the physiological stress of the event, leading a physician right down the path of a myocardial infarction.
So the takeaway for the exam is to maintain a massive index of suspicion for anyone over 60 with cardiovascular risk factors presenting with new abdominal or back pain.
Absolutely. Now, the diagnostic routing in these suspected cases depends entirely on one factor: hemodynamic stability.
Okay, so if the patient is hemodynamically unstable, meaning they're hypotensive, tachycardic, or have an altered level of consciousness, they do not go to the CT scanner.
Do not send them to CT. Sending an unstable patient down the hall to the radiology suite is a massive legal and clinical liability. They will code in the scanner.
They go straight to the operating room, or you utilize a bedside ultrasound right there in the trauma bay to quickly confirm the presence of free fluid and the aneurysm.
Conversely, if the patient is hemodynamically stable, the diagnostic study of choice is a CT angiogram of the abdomen and pelvis.
Because the IV contrast maps out the anatomy, shows the exact location of the rupture, details the involvement of the renal arteries, and basically gives the vascular surgeon a roadmap for the repair.
Exactly. But while we're discussing the immediate resuscitation of that unstable patient, there is a very counterintuitive trap regarding 5E fluids.
Oh, right. When a patient arrives hypotensive, the immediate clinical reflex is to hang bags of normal saline and crank their blood pressure back up to a normal 120/80.
But the sources heavily emphasize the concept of permissive hypotension.
Because if you aggressively normalize their blood pressure, you risk literally blowing out the natural clot.
Yeah. When the aorta ruptures, it often bleeds into the retroperitoneum, and this is a confined anatomical space,
Right, so as the blood pools, the tissue pressure pushes back against the aorta.
creating a temporary tamponade effect. It's like a fragile natural stab that slows the bleeding.
So if you pump the patient full of fluids and drive their systolic pressure up to 140, the hydrostatic pressure inside the aorta overcomes that retroperitoneal resistance. You pop the seal.
And the patient bleeds to death on the stretcher.
The goal is to target a systolic blood pressure of just 80 to 100 millimeters of mercury.
You keep them conscious, you keep the vital organs barely perfused, but you do not pop the clot.
And when it comes time to actually transfuse blood products, it requires a massive transfusion protocol, right?
Yes. You want a 1-to-1 ratio of packed red blood cells to fresh frozen plasma.
Because the patient isn't just losing red blood cells, they're bleeding out their clotting factors and platelets too.
Right. You are effectively attempting to replace whole blood to prevent the coagulopathy of trauma.
Okay, so a rupture is the catastrophic outward failure of the entire full-thickness wall. But the exam also loves to test a different kind of high-pressure emergency, one where the wall doesn't burst outward, but instead delaminates inward.
Ah, the aortic dissection.
Exactly.
The pathophysiology here is completely different. The tear occurs in the intimal layer, the innermost lining of the aorta, allowing high-pressure blood to surge into the middle layer, the media.
The best physical analogy I've found for this is a tear in the inner lining of a winter coat.
Oh, I like that.
Yeah, imagine you're walking outside in a severe storm. The wind catches a tiny tear in the silky inner lining of your coat, and the sheer force of that wind rips the layers of the coat apart from the inside. In this scenario, the blood is the wind, ripping a channel between the intima and the media, creating what we call a false lumen.
And the underlying condition that makes that inner lining susceptible to tearing in the first place is called cystic medial degeneration.
Which is the breakdown of the smooth muscle and elastic fibers in the aortic wall.
Exactly. And the number one driver for this degeneration is chronic hypertension. It is present in roughly 75% of acute aortic dissection cases.
Because the constant, decades-long pounding of high blood pressure damages the vasa vasorum, those tiny blood vessels feeding the aorta that we mentioned earlier.
Yep. And when the vasa vasorum are damaged, the aortic wall suffers from ischemia. The tissue literally undergoes necrosis, weakening the structure until it finally just snaps.
We also have to account for genetic factors too, right? Particularly in younger patients who present with dissections without any history of hypertension.
Right. Connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome, they inherently weaken those elastic fibers from birth, leading to premature cystic medial degeneration.
Now, anatomically, the exam requires you to know the Stanford classification system. Type A involves the ascending aorta, regardless of how far down the tear propagates.
And type B involves only the descending aorta, distal to the left subclavian artery.
The clinical implication is straightforward, though. Type A is an absolute surgical emergency due to the risk of the tear marching backward into the heart.
Whereas type B is generally managed medically with strict blood pressure control, unless there are severe complications like organ ischemia.
And the classic presentation for a dissection is sudden, severe, tearing or ripping chest or back pain.
Unlike the pain of a myocardial infarction, which often builds in intensity over minutes, dissection pain reaches its maximal intensity immediately at the moment of the tear.
You are actively looking for blood pressure discrepancies on physical exam, right? Like a difference of greater than 20 millimeters of mercury between the right and left arms.
Yes, that discrepancy happens because the dissection flap can physically propagate across the aortic arch and act almost like a curtain,
Covering the origin of the left subclavian artery and basically cutting off the blood pressure to that arm.
Exactly. You might also auscultate a brand new diastolic murmur. As the false lumen expands backward toward the heart, it dilates the aortic root, pulling the aortic valve leaflets apart and causing acute aortic regurgitation.
Furthermore, up to 20% of patients present with stroke-like symptoms or limb weakness.
Because the dissection flap is starving the carotid or spinal arteries.
Which brings us back to the hook from the beginning of our deep dive.
Ah, yes.
The patient looks exactly like they're having a heart attack. The standard emergency workup for severe chest pain is an ECG and a chest x-ray.
And the classic textbook finding for dissection is a widened mediastinum on the x-ray caused by the blood filling that false lumen.
But relying on that x-ray is a massive trap. Up to 20% of aortic dissections present with a completely normal chest x-ray.
It gets worse. About 8% of these patients will present with ECG changes, like ST segment elevation, that perfectly mimic an acute myocardial infarction.
Because the dissection flap physically tears into the origin of the coronary arteries, depriving the heart muscle of oxygen.
Exactly. So if a clinician sees ST elevation and assumes it's a standard clot-driven heart attack, they will administer blood thinners or thrombolytics, clot busters.
And giving a clot-busting drug to a patient who is actively bleeding into the wall of their aorta will cause them to rapidly bleed out into their pericardial sac,
Causing fatal cardiac tamponade.
This is why you cannot assume a normal X-ray means a safe heart attack. The gold standard for ruling in a dissection is a CT angiogram.
And once the diagnosis is confirmed, particularly for a type B dissection or while you're stabilizing a type A for the operating room, there is a strict, non-negotiable sequence for medical management.
Okay, this is high yield.
You must administer intravenous beta blockers first. Then, and only then, can you administer intravenous vasodilators to lower the overall blood pressure.
The order is entirely about physics. The tear is being driven by shear stress, specifically the velocity of the blood being ejected from the left ventricle. In physics, we look at the change in pressure over time, or dPdt.
Right. So if you give a vasodilator first, the blood vessels relax and the systemic blood pressure drops.
And the body's immediate reflex to a sudden drop in blood pressure is reflex tachycardia. The heart starts beating faster and cracking with much more force to compensate.
The heart effectively turns into a physiological jackhammer against that fragile, torn intima. You will increase the shear force and actively propagate the dissection further down the aorta.
That sounds disastrous.
It is. Beta blockers lower the heart rate and decrease the force of myocardial contraction. They blunt that shear stress.
Once the heart is calmed down and the dPdt is controlled, then you can safely introduce vasodilators to bring the overall hydrostatic pressure down to a safer level.
Exactly. So the sequence of medications literally dictates the patient's survival.
Okay, so we have spent this time looking at acute, catastrophic structural failures of the central aorta. Let's look at a different type of progression. We're moving down the vascular tree to the starved periphery, peripheral arterial disease, or PAD.
We are shifting from sudden tears and rapid internal bleeding to chronic progressive occlusions in the distal branches of the legs. This is atherosclerosis, causing a simple supply and demand mismatch.
Right. The pipes are gradually getting clogged with cholesterol plaques over decades.
And the clinical hallmark is claudication. A patient walks 2 or 3 blocks, and they develop severe cramping pain in their calves or thighs.
They stop and rest for a minute, the pain completely resolves, and they can walk again.
Yeah. The skeletal muscles require significantly more oxygen during ambulation, but the atherosclerotic narrowed arteries simply cannot increase the blood flow to meet that demand.
So the muscle becomes ischemic and cramps.
Exactly. When the patient stops walking, the oxygen demand drops back down to baseline, and the pain resolves. But as the disease progresses, it advances to critical limb ischemia. The blood flow is so poor that the tissues are starving even at rest.
And the classic description of ischemic rest pain is a severe burning sensation in the toes or the soles of the feet, particularly at night when the patient is lying flat in bed.
Because the loss of gravity makes it even harder for the weak arterial pressure to push blood all the way to the toes.
To relieve the pain, patients will literally dangle their legs over the side of the bed or sleep sitting up in a chair.
They're using gravity to pull just enough extra arterial blood down into the feet to temporarily relieve that tissue starvation.
But wait, if a patient comes into the clinic just complaining of leg pain when they walk to the mailbox, why is their overall mortality suddenly a massive concern? I mean, it seems like an isolated issue with their mobility.
Right, but we need to view PAD not as an isolated disease, but as a systemic warning sign. A useful analogy is the check engine light on a car's dashboard.
Oh, I like that.
The blinking light is isolated to the plastic dashboard, but it tells you the engine is about to fail. If the arteries in a patient's legs are clogged enough to cause claudication, you can virtually guarantee the arteries in their heart and their brain are severely narrowed as well.
So patients with PAD have a cardiovascular risk equivalent to someone who has already survived a myocardial infarction.
Precisely. Now, the objective diagnostic test the MCCQE will look for is the ankle brachial index, or ABI.
It's a bedside test. You place a Doppler ultrasound probe over the dorsalis pedis, or posterior tibial artery in the foot, inflate a blood pressure cuff around the calf, and compare that systolic pressure to the systolic pressure in the arm.
A normal, healthy ABI ratio is between 0.9 and 1.3.
And PAD is formally diagnosed when the ABI drops below 0.9.
Right, the pressure in the ankle is lower than the arm because the atherosclerotic plaques are blocking the blood flow down the leg.
But the major exam trap lies at the other end of the spectrum, an ABI greater than 1.3. Intuitively, a student might think, well, the pressure is really high in the leg, so the vessels must be super healthy and robust.
But that logic will cost you points. An ABI greater than 1.3 indicates medial calcinosis.
Oh, so the vessels have become so severely calcified and stiff that they have turned into non-compressible lead pipes.
Exactly. This is extremely common in patients with long-standing diabetes or end-stage renal disease. The blood pressure cuff physically cannot squeeze the hardened artery shut, which gives a falsely elevated, abnormally high-pressure reading.
So if the vignette shows an ABI of 1.4, the next step is alternative imaging, like toe brachial indices or arterial duplex ultrasound, because the standard ABI is completely uninterpretable.
Yes. And for management of claudication, the immediate instinct might be to consult vascular surgery to bypass the blockage. But the standard of care actually begins with conservative management.
Supervised exercise therapy is highly recommended. By forcing the patient to walk until they experience mild pain, it signals the body to undergo angiogenesis, basically building new collateral blood vessels around the blockages.
And systemic risk factor modification is equally critical to prevent that impending heart attack or stroke. Smoking cessation is non-negotiable.
Every patient diagnosed with PAD should be placed on a high-intensity statin and antiplatelet therapy, such as aspirin or clopidogrel, regardless of their cholesterol levels.
There is also a specific pharmacologic agent used to treat the claudication symptoms themselves, cilostazol.
It's a phosphodiesterase type 3 inhibitor that promotes vasodilation and prevents platelet aggregation, helping patients walk further without pain.
However, the sources highlight a black box warning that is frequently tested. Cilostazol is absolutely contraindicated in patients with congestive heart failure of any severity.
All right. Studies have shown that PDE3 inhibitors increase mortality in heart failure patients. So if the clinical vignette mentions a patient with an ejection fraction of 30% or a history of heart failure exacerbations, you must avoid cilostazol.
Wow, okay. We have covered a massive amount of clinical ground today. Let's run through a rapid-fire, high-yield summary of the diagnostic thresholds and rules.
Let's do it. For abdominal aortic aneurysm surgical thresholds, intervene electively at a diameter greater than 5.5 centimeters in men, 5.0 centimeters in women, or if the aneurysm expands more than 0.5 centimeters in 6 months.
For ruptured AAA, the classic triad of hypotension, back pain, and a pulsatile mass is only present 25 to 50% of the time. If the patient is unstable, skip the CT scan and go straight to the OR, maintaining permissive hypotension systolic 80 to 100 so you do not blow out the retroperitoneal clot.
For an aortic dissection, administer 7 beta blockers first to blunt the shear stress and limit reflex tachycardia, followed by vasodilators. Never the other way around. And remember that a completely normal chest X-ray does not rule out a dissection.
For peripheral arterial disease, it is a systemic marker for cardiovascular mortality. An ABI less than 4.9 diagnoses PA, while an ABI greater than 1.3 indicates heavily calcified, non-compressible vessels heavily associated with diabetes.
Great summary. Before we wrap up, I want to leave you with a final thought to ponder. We've spent this entire deep dive exploring how identical systemic disease processes, atherosclerosis, chronic hypertension, tissue inflammation, result in completely different catastrophic events depending entirely on where they strike along the vascular tree.
Yeah, the underlying systemic disease is identical, but the architectural reality of the specific vessel dictates the presentation.
Consider how the microscopic anatomy quietly determines a patient's destiny decades before they ever feel a symptom. The sheer density of those lamellar units in the infrarenal aorta, or the health of the microscopic vasa vasorum feeding the aortic wall in the chest.
These invisible cellular landscapes are what decide whether a patient will suffer a slowly ballooning aneurysm, a sudden tearing dissection, or a silent peripheral blockage that eventually claims the limb.
The structural flaw is microscopic, but when the pressure hits, the outcome is absolute.
Very true. Best of luck on your MCCQE prep. Keep practicing those clinical vignettes, and remember to look for the traps.
We'll see you on the next deep dive.